So the question is, which of the following are useful investigations for diagnosis of unresponsive endometrium as a cause of primary amenorrhea? So a patient is coming to you with primary amenorrhea. So there are various causes of primary amenorrhea. One of them is unresponsive endometrium. Unresponsive endometrium. So what is unresponsive endometrium? Unresponsive endometrium means that endometrium is not responding to even normal level of hormones like estrogen and progesterone. So estrogen and progesterone are normal, but still endometrium is not responding to them. So how will you diagnose? So first is karyotyping. So karyotyping has no role in diagnosing unresponsive endometrium. Second is progesterone challenge test. Yes, it has a role. What is progesterone challenge test? So in the progesterone challenge test, we give progesterone for certain days. So progesterone is given for certain days, is given, and then all of a sudden it is withdrawal, it is stopped. So when you stop it, if there is bleeding, it means progesterone challenge test is positive. If there is no bleeding, it means progesterone challenge test is negative. So let us understand what is progesterone challenge test principle. So we know that for endometrium growth, so for the growth of endometrium, what is important? Estrogen is important for growth. And for its development, basically for the secretory changes, the progesterone is required. So both are required. But if there is no estrogen on the very first place, if the estrogen is not present, the progesterone will not be able to act on the endometrium because the growth is primary responsibility of the estrogen. So if there is no estrogen, progesterone has nowhere to act. So if we give progesterone, let us suppose we give progesterone in the progesterone challenge test, and after giving progesterone, bleeding occur. It means that the estrogen was present, and so endometrium was growing well, and it was the problem in the progesterone which was leading to the amenorrhea. And once we gave progesterone, the development also took place, and that's why the bleeding took place. So if the progesterone challenge test is positive, it means that the problem was somewhere in the progesterone thing. Okay, so if the progesterone challenge test is positive, it means that what is ruled out? It means the ruled out thing is that estrogen thing. So hypothalamic pituitary ovarian axis is normal. It means it is normal, because if it would have not been normal, the estrogen would not have been normal. So it means hypothalamus is normal, pituitary is normal, and ovary is acting normal. Second, estrogen is adequate. Estrogen is adequate enough to promote the growth of endometrium. So estrogen is normal. Third is the outflow tract anatomy. Outflow tract anatomy is intact. So your cervix is intact, your vagina is intact. So that's why bleeding took place. The fourth is your endometrium is responsive to hormone. Endometrium is responsive to hormone. Endometrium is responsive to hormone. So so where is the problem? If it is positive, it means the problem was in progesterone. So estrogen is not a problem, but progesterone is problem. So what is the disease? For example, what are the examples of disease in which it can take place? So PCOS, polycystic ovarian syndrome. So in the polycystic ovarian syndrome, there is problem in the ovulation. So ovulation will not take place. So the developing follicles will keep on releasing estrogen. So endometrium keep on growing. So estrogen is fine, but because ovulation is not occurring, so corpus luteum will not form. And when corpus luteum will not form, the progesterone will not be released, because it is the function of corpus luteum to release the progesterone. So such disease will occur. So this was the principle of progesterone challenge test. So coming to the second option, progesterone challenge test, yes, it is important, because in the case of unresponsive endometrium, progesterone challenge test will be negative. So it is important. Third is hormonal studies. It is important because in hormonal studies, we will come to know that the estrogen is normal and progesterone is normal. So everything like your FSH normal, LH normal, everything is normal. In the histosalpingography, yes, histosalpingography is done so that you can find out the anatomy of the things. Okay. So the correct option will be 2, 3, and 4. So 2, 3 and 4 is the correct answer. 1. The karyotyping has no role in finding the in making the diagnosis of unresponsive endometrium. Now coming to the 62nd. A 16-year-old girl with primary amenorrhea. So there is a 16-year-old girl with primary amenorrhea presenting to the gynecology OPD for evaluation. Now, when you examined her, you find that she has a normal secondary sexual characteristic. Her karyotyping is 46XX, means it's normal. And the ultrasound reveals normal ovaries and tubes but absent uterus. So the ultrasound reveals that the ovaries are normal, tubes are normal, but uterus is absent. What is the clinical diagnosis? So first is androgen insensitivity syndrome. No. In androgen insensitivity syndrome, it is 46XY. The genotype is male genotype. And because of the deficiency of androgen receptors, there is the male masculinizing characters did not appear. So the androgen insensitivity syndrome will not occur. So it's not 46XX, it should be 46XY. Coming to Turner syndrome. Turner syndrome is 46X. So it is 45XO. Then coming to the Mayer-Rokitansky-Kuster-Hauser syndrome. Yes, this is correct because this means Mullerian agenesis. Mullerian agenesis. That is, and the Mullerian. So what is Mullerian agenesis means? That Mullerian duct is not formed. So Mullerian duct forms your uterus, your fallopian tube, and upper 2/3 of vagina. So this will not be present. So C will be correct answer. Primary ovarian failure. So if there will be primary ovarian failure, the ovaries cannot be normal. So, but the question says the ovaries is normal. So normal ovary is present. And there is also normal secondary sexual characteristic. Secondary sexual character. It means estrogen is also normal. So it cannot be primary ovarian failure. So the correct answer will be Mayer-Rokitansky-Kuster-Hauser syndrome. So what is MRKH? So what is MRKH? Mayer-Rokitansky-Kuster-Hauser syndrome. So it's a problem of Mullerian agenesis. So there will not be development of uterus, cervix, and upper 2/3 of vagina. But ovaries develop normal. Because ovaries have different embryological logic, they do not develop from the Mullerian duct. Second, because ovaries are normal, so your estrogen will be normal. Now, because estrogen is normal, so your breast will be normal. So your breast development will be normal. And pubic hair and axillary hair, because they depend on the androgens, so the pubic axillary hair will be normal. Patient's karyotype will be normal female karyotype, so that is 46XX. So the answer is C, Mayer-Rokitansky-Kuster-Hauser syndrome. Now coming to the next, a 25-year-old female comes to gynecology OPD for evaluation of secondary amenorrhea. So secondary, what is secondary amenorrhea? Secondary amenorrhea means initially, earlier, the patient was having the regular menses, but now she is having amenorrhea. Now there is absence of menstruation. Primary amenorrhea means that patient never experienced menstruation in her life. But secondary amenorrhea means previously there was menstruation, but now there is absence of menstruation. Now, she gives history of previous DNC dilatation curettage took place. Her FSH levels are 8 international unit per liter. It means normal. So normal FSH levels are there. What is the probable cause of the amenorrhea? Sheehan syndrome, Asherman syndrome, premature ovarian failure, or incomplete abortion. So there are some important clues. First is there is secondary amenorrhea. Second, there is history of DNC. Third, FSH is normal. So the answer will be Asherman syndrome. What is Asherman syndrome? Asherman syndrome means intrauterine adhesion formation or synec formation, which are not letting the endometrium shed off. So endometrium can't be shed off. Can't be shed off. Shed off. Endometrium cannot regenerate normally. So secondary amenorrhea will be there. Now, in this case, why do Asherman syndrome take place on the first place? So whenever we do D and C following abortion, or there is postpartum curettage, postpartum curettage, or some uterine surgery, Asherman syndrome can take place. Uterine surgery. What is the significance of saying that the FSH is normal? FSH is normal means ovary is functioning normally. Ovary is functioning normally. Functioning normally. Now, coming to other options. So, other option first is Sheehan syndrome. Why is it not a Sheehan syndrome? The patient is not giving history of PPH. So, Sheehan syndrome occurring previously severe PPH, or there is some history of pituitary infarction, or failure of lactation. So, whenever the answer will be Sheehan syndrome, such history will be present in question. Or there is low gonadotropins like low FSH or low LH will be there. So, no such history is given. Plus, DNC history points toward the Asherman only. So, A is wrong. Now, coming to premature ovarian failure. So, because FSH is normal, so it is saying that the FSH is normal. FSH is normal. So, premature ovarian failure cannot be there. If there would have been premature ovarian failure, in that case, FSH would have been high and so estrogen would have been low. Because, it is other way around, that because of premature ovarian failure, the estrogen is low, and so the feedback inhibition will not be there, so FSH will be high. But in this case, the FSH is normal. Now, coming to why is there not incomplete abortion? Because incomplete abortion will present with vaginal bleeding. On the very first place, there will be vaginal bleeding. The history will be retained product of conception. Cervical os will be open. Now, coming to the last question, 64th question. Which of the following criteria are required to be fulfilled for hospitalization in a case of pelvic inflammatory disease? So, there is a patient of pelvic inflammatory disease coming to you. So, how will you decide that that patient has to be treated on OPD basis, or you have to admit an patient? So, first is coexisting pregnancy. Yes, coexisting pregnancy is one of the criteria for hospitalization. The fever is mild and the pain is responding well to antibiotics. No, this cannot be. If the patient is responding well to the antibiotics, why are you going to admit that patient? You are going to continue the OPD treatment only. Suspected tubo ovarian abscess, yes, this is correct. Coexisting HIV infection, yes, this is correct. So 1, 3 and 4 will be the correct option. So answer A will be the correct option. So this question has been taken from the Datta's textbook, in which table 10.5 there is indications for hospitalization which are taken from the guidelines of CDC 2006. So what are other indications? So one is suspected tubo-ovarian abscess. Second, there is severe illness, vomiting, temperature more than 38 degrees Celsius. There is some uncertain diagnosis where surgical emergencies like appendicitis cannot be excluded. Or the patient is unresponsive to outpatient therapy for 2 days, for 48 hours. The patient is intolerant to oral antibiotics. The patient is having coexisting pregnancy. And the patient is known to have HIV infection. So in these conditions, you are going to hospitalize the patient and start the IV antibiotics.